Of CME Outfitters, I'd like to welcome you to the first of 4 podcasts in the series, Castration-Sensitive Prostate Cancer, Navigating the Current Diagnostic and Treatment Landscape. Today we're going to talk about disease states of castration-sensitive prostate cancer. As mentioned, I'm the Cora Sternberg, Clinical Director of the Englander Institute for Precision Medicine, Professor of Medicine at the Sandra and Edward Meyer Cancer Center at Weill Cornell Medicine in New York. And I'm joined by my esteemed colleague, Dr. Anthony Sisk, who is Assistant Professor in Pathology at the University of California in Los Angeles, California. Welcome, Anthony.
Hi, nice to be here.
Great. The learning objectives today are first to outline the current state of pathologic characterization of castration-sensitive prostate cancer, and secondly, to interpret the findings of reports detailing the pathology of prostate cancer specimens. Anthony, perhaps you'd like to look at this slide and tell everyone a little bit about the evolution of the Gleason score.
Sure, that's great. So the Gleason score is the best method that we have now for evaluating and grading prostate cancer. In the beginning, I'd say before the mid-1960s, it was kind of a free-for-all, and it didn't correlate too well, and it made management of patients difficult. So Dr. Gleason, around the mid-1960s, was tasked with the job of creating a better system. He was a VA pathologist, so he had access to a large population of prostate cancers. And he developed a system that eventually became known as the Gleason grading system, based on 5 different pretty distinct patterns, and these patterns correlated very well to patient outcome. And you can see in 2005 there's actually been an iteration based on the International Society of Urologic Pathology's membership discussion, and then again in 2014 we had another iteration where there was slight changes in based on morphologic patterns, based on updated studies.
And based on what happened to patients with these different patterns, I imagine.
Correct.
You want to go through the patterns a little bit?
Sure. So the before slide showed a kind of a cartoon representation, but here are the actual histologic sections based on hematoxylin and eosin staining, where it starts out as a grade 3, which is a most well-differentiated form of prostate cancer. Typically, on the upper left slide, you can see small glands that are infiltrating in between these larger non-cancerous glands. The slide below that gives you a good picture of what the histology looks like. And these are well-formed glands where you can actually draw a line around them because there's stroma encircling each gland, and it has a nice open, well-formed lumen. And as you move from patterns 3 to 5, it becomes less and less differentiated. As a pattern 4, you can see at the kind of on the top slide, you can see the glands are very small. You're not seeing distinct lumens. And on the bottom slide, there's additional pattern 4 where you have the glands attempt to coalesce to one another, which is called fusion or small cribriforming. And then if you look in the middle of this picture, in addition to that, there's a pattern 4 which has an even more aggressive pattern or aggressive outcome, and that's your large cribriforming. This is based on typically 12 or more lumens, and it tends to be large where it expands the entire width of a needle core biopsy. And then lumped into this is your ductal carcinoma, not described in Gleason's original grading scheme, but by convention, because it has a similar outcome to grade 4, it is assigned a grade 4. And then we move finally to pattern 5, the least differentiated, where you have no attempt at all at gland formation, where you have single cells, sheets, or cords of cells. And on the bottom picture where it says single cells, you can just see the difference between the prior slides, the prior pictures. There's no real gland formation here. This is just a sheet of single cells. And then finally, necrosis, a distinct feature that's assigned pattern 5, typically seen in a large cribriforming unit that has a very high rate of proliferation, where you have tumor necrosis within the central, within the lumen of this gland, and it creates this kind of expansile look. If you see on the bottom right picture, there's a lot of karyorectic debris, and you can see ghost tumor cells, or this tumor cell necrosis.
Yeah, so I think it's very clear that from these beautiful pictures how the difference between 3 and 5.
Right.
What about the grade groups?
So the grade group system was created in 2014 and placed in the 2016 WHO, and it's a system to try to clarify some of the shortcomings or some of the confusing points of the Gleason grading system. So you have grade groups is broken into 5 different groups, and it correlates to a distinct Gleason score or scores, whereas grade group 1 is a Gleason score 3 plus 3 equals 6. Grade group 2 and 3, although both Gleason score 7, they're distinguished between 3 plus 4, which is kind of a low-grade intermediate, versus 4 plus 3, which is more of a high-grade, more aggressive intermediate carcinoma. And then you have your grade groups 4 and 5, which are your high-grade carcinomas, distinguished between Gleason scores 8 and 10. And this is all based on the Gleason score system.
I know there was quite a bit of discussion about the grade group 1, whether or not to even call it a cancer when this was discussed, because it was thought that these patients did very well and maybe they shouldn't be called cancer at all. I know there was a lot of discussion.
Right, yeah. Yeah, it is helpful actually, because when you get a diagnosis of a Gleason score of 6 or 3 plus 3, to a patient's eye, that's over halfway, because the Gleason score goes from 2 to 10. And a 6, that doesn't sound very good. So one of the advantages of the grade group is that it kind of takes that into consideration, where you're now in a grade group 1, you're in the first group, so that, helps the patient kind of understand where his diagnosis is at.
And this is often incidentally found. For example, when a patient has a cystectomy, they'll have a Gleason 6 prostate cancer found. It really is just an incidental prostate cancer as well.
Right. Yeah, we see it all the time on for BPH, simple prostatectomies and TURPs.
Exactly. Can you talk about the grade group validation?
So correct. There's been several large studies performed that correlates the outcomes with grade groups, and the correlation is quite strong. This multi-institutional study led by Epstein and others that was published back in 2016, the European Urology, showed that there was a hazard ratio of biochemical recurrence relative to grade group 1 was quite distinct per each grade group. So when you go to grade group 2, you can see a hazard ratio of 1.9, meaning there was a slight increase in the risk of recurrence. Whereas when you see in grade group 3, 4, and 5, it actually goes up significantly more. So these are very large studies which showed strong correlation between grade groups and outcome.
And they also looked in racially diverse groups of patients as well.
Right.
At this.
So the SEER data was based on 330,000 racially diverse patients. So, race was taken out of the picture. So overall, it's a very strong method in order to predict patient outcomes.
Yeah.
And this is a graph, a little bit more detail from Dr. Epstein's study. This is looking at biochemical recurrence-free progression probabilities. Just to give you an understanding of the differences between grade groups 1 through 5, you can see grade group 1, the biochemical recurrence-free progression is at 96%, whereas grade group 2 is only slightly worse. The difference is grade group 3, 4, and 5, we have a pretty striking increase in the chance of recurrence, which is very helpful for patients to understand when you have a grade group 2 versus grade group 3. Although the Gleason score is still 7, the WHO grade group 2 and 3 has a significant difference in risk of recurrence.
After radical prostatectomy.
Right.
Yeah.
Yeah, this is based on radical prostatectomy evaluations.
So can you discuss a little bit further the advantages and limitation of these grading groups?
Right. So, with Gleason, same thing with the Gleason score. There's limitations. A lot of it is subjectivity and recognizing what pattern is 4, 3, or 5. So, nothing's perfect. The grade group does help kind of alleviate some of those issues, but the grade group system is not perfect, and it's fairly new, so there will probably be iterations to that similar to the Gleason scoring system. Some of the advantages we kind of already went over is that a grade group of 1 sounds a lot better, at least to a patient's mind, as opposed to a Gleason score of 6, which is over halfway to 10. And it also kind of takes into consideration that there's no real Gleason, and the diagnosis of Gleason pattern 1 and 2 just doesn't exist anymore. It's very rare. So it kind of takes that out of the picture and kind of equalizes how we diagnose these. In addition to that, it distinguishes nicely the difference between a Gleason score 7, where you have 3 plus 4 intermediate low grade versus or I should say low risk, versus a 4 plus 3 intermediate, but more of a high risk, as we saw from those graphs. And in addition, when you have the grade group 5 or a Gleason, anytime you have a Gleason pattern 4 plus 5 or higher, the prognosis is pretty much the same. So if you have 5 plus 5 versus 4 plus 5, clinically that's not significantly different. So all of those get kind of lumped into a grade group 5. So it helps kind of make sense of these different high grade carcinomas. There's a couple of drawbacks to the grade group systems. One is the grade group 4, and the problem with that is that when you have a Gleason score of 3 plus 5 and a Gleason score of 5 plus 3, there's just not a lot of these. These are very rare, so there's not a lot of studies with those particular grade groups. Right. So this is an overview of how we report the grades, and it does make a difference whether it's a biopsy or a resection. When it's only 1 grade, it's essentially primary and secondary is the same, as you see. 3 plus 3 equals 6. So I guess to keep things the same, because we're doing 2 scores. When you have 2 different numbers, it makes sense when it's a 3, 4, 7. But when it's only 1 grade, it would kind of be silly to say just 3. So we try to make things simplified. So we call it 3 plus 3 equals 6, or 4 plus 4 equals 8. So, but then when we have more than 1 grade, that's when you have to kind of add things up, which is either a more common grade or a more aggressive feature, depending on whether you're doing your score on a biopsy or a resection. So, for instance, on a biopsy, you only have 2 scores. In the past, and maybe some of the older pathologists may still put a tertiary pattern within your biopsy. That's just not really accepted by most leading experts these days. It's just something that's kind of old school, I guess we could say. Because
if they've had 18 biopsies, it's not done.
What's that?
Even if they've had many biopsies, like 18 biopsies.
Right. Right.
Okay.
Now, the thing is, on a targeted biopsy, things are changing. The way we report this, there may be some changes. But in general, in our systemic biopsies, if you have a tiny component of a higher grade, it's a small biopsy, 1/1000th of a sampling of a tumor, something like that. So the chances of having much more of that in the prostate or within that lesion in the prostate is much higher. So we don't do the tertiary pattern on a biopsy. So if you have say grade 3 is 60%, 4 is 35%. If you have a grade 5 that's say 3 or 4%, just a small area, you'd call that 3 plus 5 equals 8. Now, if this was on a resection, and say you had a dominance of pattern 4, second most common is pattern 3, but your third pattern is less than 5%, this now becomes a tertiary pattern. We would call that 4 plus 3 equals 7. Now, if that 5%, that grade 5 was 10%, then that's above that cutoff to call it a tertiary pattern, and it actually goes to 4 plus 5 equals 9. So it can be a little bit subjective, especially when the pattern is getting close to those cutoffs. Is it a 4? Is it 4% or is it 6%? It can be kind of subjective, and there is a push by some to just get rid of the tertiary component altogether. If you have any higher amounts, you just call it those 4 plus 5 or 3 plus 4, whatever it might be,
and not try to calculate the percentage with the naked
Correct.
eye
Of the tertiary, right?
The tertiary. Yeah. So you want to just summarize here what you've just told us with contemporary Gleason grading?
Yeah, correct. So yeah, now it's essentially a requisite that we put a pattern 4 percentage in the report. And this mostly goes for patterns 3+4, but it's also highly recommended for 4+3. And that's because when you have increasing numbers of pattern 4, it's no longer low volume 4. Then it indicates to the surgeon or to the hematologist, whoever's managing the patient, that this patient possibly needs to be, the therapy needs to change, maybe no longer amenable to active surveillance, or there's some other therapy that focal therapy is another possibility. So we give these percentages. When you have a core that's high grade, say 8 or 9, then it really doesn't make any difference anymore, because now we have a high grade carcinoma. It's irrelevant whether there's 20% pattern 4 or 5% pattern 4. You have a Gleason score, 4+5 on another core, so it's not as significant. Pattern 5 percentage is not necessary on a biopsy. Doesn't make any sense. Any pattern 5 at all is just goes immediately to either 3+5, which is extremely rare, or the more common 4+5. And the other thing that's kind of now in play is the presence of a minor component of a lower grade. Say you have a couple of glands of 3 in a core, which has diffuse pattern 4. It would make no sense to call that a 4+3. You just exclude those couple of glands of 3, and you just call that a 4+4.
Because that's going to drive the prognosis for sure.
Right.
So there are still some controversies in the last 2019 publication, right?
Yes. Yeah, there's been some controversies and some changes that have been recommended by the ISUP. We kind of went over this top one here. So it's losing its luster to call something 3+3 tertiary pattern 5. Essentially, as I've mentioned, there's no real difference between 3+3, clinical outcomes, and a very low volume pattern 5. So instead of just saying 3+3 tertiary pattern 4, just call it 3+4. However, it's not so accepted to do that with 4+4 when you have a minor component of 5. So you can, seeing a diagnosis of 4+4 with tertiary pattern 5 is much more common, and it indicates a much worse outcome. Although the grade group is still grade group 8. Grade group 4. And then, as I've mentioned, targeted biopsy. It's a new thing. As it advances in MR technologies and the PIRAD system, we can better see and visualize lesions. Even staging of the lesion based on MR has vastly improved. So we can get samples of these biopsies, kind of like in a breast mass where you get multiple cores. You can do the same thing in prostate, but that brings up the problem of grading. When you have multiple cores of the same lesion, but they differ, if say one core is 4+4 and another core, have a bunch of 3+4. A lot of urologists, particularly here, they just take the highest number and say, oh, this is a 4+4 lesion. But in reality, if you look at the global score, there's a lot of 3+4s with only one 4+4, meaning that the global score is probably a 3+4 on that. And it's recommended by ISUP, by the majority of members, to come up with some kind of method for reporting the global score. And they made this recommendation before any real studies have come out. And there have since 2019, when they first made this recommendation, been a couple of studies that have shown good correlation in doing the global score rather than individual core scoring. But they're kind of small studies, and there's just no real good validated method, and it's really difficult to try to do. Most of the time, it doesn't matter because the lesions are very similar, because the tumor might be more homogeneous. When you get these heterogeneous tumors, you have a high grade in one area and a low grade in another area. It can be quite difficult to actually come to a conclusion of the overall global scoring. In a lot of places, just haven't done that because there just hasn't been a real good validated method in how to do this.
Things obviously are changing as we become more sophisticated with our MRI and our targeted biopsy.
Yes.
Would you like to talk about cribriform pattern?
Sure. Yeah. So some of the other recommended changes and controversies brought up by the last meeting from the ISUP includes the presence of large cribriforming units or cribriforming glands. Now, as I showed you the picture of these glands, essentially they're cribriforming, but they're very large, meaning they have greater than 12 lumens, and they often will span the core of the biopsy needle, core. And studies have shown these actually have a much worse outcome than those of smaller cribriforming or the just kind of early cribriforming features. So it has been recommended that we would include these in particularly the biopsy, but also the resection. And on a biopsy, you just kind of mention cribriforming, large cribriforming present or not present. Whereas in a resection, you have a whole tumor to look at. You can actually give a percentage if you'd like. I tend to go with just focal and extensive to make it easy because it's a bit subjective to give a percentage, but it does indicate a worse outcome, and patients may need to be followed more closely because their risk of recurrence is increased with these large cribriforming features.
What about?
And then the other thing is intraductal carcinoma.
Mm-hmm.
In the past, before we had this utility of the immunohistochemistry stains, or what we call the PIN4 to look for basal cells to determine whether it's invasive or not, intraductal carcinoma was just graded into the prostate cancer. It just didn't really understand its presence. But now we recognize it as a very aggressive pattern, different from high-grade PIN, in that this is actual cancer, high-grade cancer that's cancerizing the ducts, and it's typically associated with very high-grade carcinoma, Gleason score 8 or higher. So it's something that needs to be reported now. And as a little side note, although this is we're not doing this yet, similar to what was in the past before we even noticed these things, there's now a push to just ignore it. When you have invasive component of adenocarcinoma and intraductal carcinoma, you just include it into the grading scheme. It's not something we're doing now, but it's something that's probably going to happen because these things are changing quite fast. And the other thing is we are recommended to report what we're seeing in a biopsy that's benign, especially in a PIRADS 4-5. So PIRADS 4-5 really correlates pretty strongly, especially PIRADS 5, almost 100%, that there's a lesion there or a malignancy. It doesn't necessarily say whether it's high grade or low grade. It's just correlates really strongly that there's a malignancy there. So whenever we have a biopsy in that region that's benign, we want to report what we might see that might help explain those findings by MR. Particularly hemorrhage has been an issue. Prostatic hyperplasia, particularly the stromal nodules, and inflammation, as well as a few other things. So we put that in the report as well.
Makes sense.
Yeah. So on this kind of brings up an issue with quantifying the amount of tumor in a biopsy. This is an example, and this is not common. This is like very, very, very uncommon. Usually tumors in the same area, and it's not an issue. But now when you have lesions on opposite side of a core, how do you quantitate that? If you just, and there's no validated method to do this. Some institutions will call this a large segment of tumor, whereas others might distinguish each individual focus and exclude the intervening benign. Keep in mind both of these cores on top and bottom, it's just one long core that's cut in half. So there's no real standard method to do that. Here at UCLA, we will kind of exclude the intervening stroma, but they need to understand that in the report. So in the report, rather than saying something's say 90% involvement, when in reality it's only 20% involvement, we might say 2 separate foci of whatever Gleason score it is, spanning the width of this amount, involving the width of this amount, of this amount, but actually occupying only this amount. Something in the report to kind of help the urologist or help the clinician understand that there's not quite as much tumor as it seems. And this can also be important when we're identifying cores for studies. if you have a core that says 90% involvement, but in reality it's not two tiny foci, you're not going to have enough tumor to do genetic studies on. So it's very helpful, to have that distinction into the report and how you're actually measuring this.
I heard a lecture once by Jonathan Epstein, and I think I understood it differently. I think he was saying that if you have at one side of the core and then the other side of the core, that you need to measure the whole thing as
right.
being involved.
That is something. So Johns Hopkins is the leader on this, and they've done studies that shows that it correlates well if you just include the entire core. The problem that a lot of people have is, are these really the same, given that they're so far apart, are these truly the same lesion? Are these just two different lesions? I think it's a little bit misleading. And in a majority of places aren't going to do this 90% involvement. I'd say most places are going to try to make a distinction of how much is there, how much is truly occupied by the tumor, and then just give a comment of, but it expands this amount.
So that's different from what I heard Dr. Epstein talking about a little bit. Right. Okay.
Yeah, they definitely do it differently based on their studies.
I remember hearing that lecture a few years ago.
But the thing is, if you're mentioning, but it expands this amount, then it's essentially saying the same thing. You're giving them the same amount of information that they do at Hopkins, but you're essentially telling them, but it actually only occupies this small amount. So as long as my point is, as long as you're including that in the report, you covered your bases.
Include everything, so then people can interpret it how they want.
Right.
To. Makes sense. So here's some reporting suggestions.
So depending on the urologist or the radiologist, oftentimes it's just one core. It makes things a lot easier. But when there's multiple cores in one container or multiple cores of the same site in a prostate biopsy or an area of a prostate, that needs to be indicated in the report. And the way you do your measurements, the way you do your volume involvement is going to change. You need to do, if there's 1 out of 3 cores involved, you need to note that, and then you'd say involving this much of this one core, and then overall give it kind of an overall percentage. So it makes things a lot more difficult and more challenging when there's multiple cores. But we need to somehow make that clear in the report. And then when we're talking about resections, now, especially in light of the advanced MR technology that we have, it's helpful to say we want to give location, size, and which tumor is dominant, or which is the dominant nodule. And the dominant nodule is essentially first based on stage, second is Gleason score, and third is size. So you can have a 3+4 that's extending into the fat or extraprostatic extension, and in another smaller nodule of 4+4 that might be more central, and that particular lesion is a T2, so it's not invading into the fat. So essentially, the one that's invading into the fat or upstaging the prostate diagnosis would become the dominant nodule. Another thing to understand is margins on the resections. We don't do margins on a biopsy. It makes no sense. But margins on the resections is different in a prostate versus almost every other organ. In that prostates, the prostate carcinomas tend to be in the peripheral zone, which is obviously the more peripheral portion of the prostate. So it can be quite close to the surgical margin. So in a breast, if it's 2 millimeters away, that's a positive margin. Whereas in a prostate, if the gland is within, say, the width of a fibroblast nucleus, or say a lymphocyte nucleus, just a tiny sliver of less than 7 microns, that's still technically a negative margin. Or if you can make out a sliver of collagen between the gland and the ink, and that the gland is not actually touching the ink, then that's technically a negative margin. What we would call a positive margin is when the gland is actually touching, or it seems to be, and it's very helpful if it's just cut in half, then we know for sure it's a positive margin. And the positive margin, depending on whether it's focal or extensive, can have a difference in outcome. If it's less than 3 millimeters, the chances of recurrence are much, much less, especially if it's a pattern 3 in that area. But when it gets to be above a 3 millimeter positive margin, then your chances of recurrence goes way up. So we also give not only that it's positive, but we need to know, they want to know the location as well as the length of margin involvement.
And people make decisions whether or not to give adjuvant radiotherapy based on that too.
Right.
Going to talk about neuroendocrine tumors?
Sure. So neuroendocrine carcinoma, or adenocarcinoma with neuroendocrine features, can be quite challenging, especially high-grade neuroendocrine carcinoma, because it can look very similar to high-grade acinar adenocarcinoma, which can sometimes give you this immature look. It can be fragile and fracture and just be very difficult. So small cell carcinoma can be difficult. Now, on the other end of the spectrum, you can have adenocarcinoma, which has neuroendocrine differentiation, say panthylic cell neuroendocrine features. Essentially, they're neuroendocrine cells with abundant granular cytoplasm that you can see in the GI tract. This can be seen on occasion in prostate cancer. In this, clinically, it doesn't have much of a difference in acinar adenocarcinoma. The problem comes with grading in that it can kind of distort the glands, and the grading of the prostate glands with these features can become difficult. The other thing is when you have neuroendocrine differentiation, that looks, if you know what a well-differentiated neuroendocrine tumor or carcinoid tumor, as called in certain organ systems. In the prostate, it's no longer referred to as carcinoid tumor. We now call it a well-differentiated neuroendocrine tumor. In that of itself, if it's the prognosis is actually quite good. But when you have acinar adenocarcinoma that's mixed with these well-differentiated neuroendocrine features, it can become difficult. So we may do certain stains to confirm that it is neuroendocrine markers like chromogranate and synaptophysin. In addition to that, we often use a proliferative marker, what's called Ki-67. It gives us a proliferative index to see what the turnover rate of the tumor is. And with small cell carcinoma, it's like 80% or higher. In well-differentiated neuroendocrine tumors, it's very low, so 20% or lower. So it can be helpful when you're unsure in a biopsy. So as you can see on the left, this is a H&E section. On the very left is just typical adenocarcinoma. You can't really make it out because the picture is small, but a higher power of that same carcinoma, you see these pink cells in these glands. These are the Paneth cell-like neuroendocrine features. That has no real significant outcome, just as I've mentioned, difficulty in grading. As you see, it kind of distorts the gland a little bit. Now on the right, you can see this really blue area. And neuroendocrine carcinomas tend to be very blue, meaning they have a lot of nucleus and not so much cytoplasm. And when it's high grade, it's extremely mitotically active, and you'll see lots of proliferative features such as karyorectic debris and apoptotic bodies. And you see the higher power image here. It's just a sheet of blue cells that are almost pure nucleus, and the nuclei are compressed to one another, and they're kind of forming around each other, creating this what we call molding. Nuclear molding is a classic feature in neuroendocrine carcinoma. So based on morphology alone, if it has these classic features, you can make the diagnosis. The problem comes when it's not quite there. It's a small biopsy. It's a small area. You're concerned whether this might be just acinar carcinoma, say grade 5, which can have an immature look. So then we would do our neuroendocrine markers and our Ki-67 or proliferative index markers to help us be more confident whether we're calling this neuroendocrine carcinoma. And it makes a huge difference in outcome, because essentially those with small cell carcinoma or any kind of high-grade neuroendocrine carcinoma, such as like large cell neuroendocrine carcinoma, which is another kind, very rare. These require cisplatin-based chemotherapies.
The worst prognosis, much worse prognosis.
Right. Intraductal carcinoma, another source of confusion for us, especially if you're in the community and you're doing the GU in the community, but you just don't have a high volume of prostate cancer or prostate biopsies, so your experience isn't that strong. Intraductal carcinoma carries a pretty heavy weight with it, and the differential includes high-grade PEN. And high-grade PEN is basically pre-neoplastic. It doesn't have that dismal prognosis that you would have with intraductal carcinoma, and it can have a very similar morphology. So it can be quite difficult. So there are some distinct morphologic patterns that you want to look for in making a diagnosis of intraductal carcinoma. One is that it's a large gland forming unit. High-grade pen is the same size as a normal gland. It's just atypical. Whereas intraductal carcinoma is markedly expanded, much larger. And in addition to that, as you can see on these pictures, it's filling a lumen. There's the white portion is the essentially represents the lumen, where you have the proliferation of cells which fills the lumen. And generally, when it's 70% or higher of a lumen, that's one of the criteria you make for intraductal carcinoma. And on the right side, a little bit higher power. If you look towards the periphery of this gland, you can almost, with experience, you can pick it up, but we still need to confirm with immunohistochemistry. But basal cells will be present. And if you're not entirely sure, the differential would be Gleason pattern 4 carcinoma. So you do your basal cell markers or your PIN4 marker to prove that this is indeed an intraductal pattern. And in addition to all of that, some of the features that help us in addition to that are the presence of necrosis. If you look towards the very center, there's a little bit of pink material. This is just a little bit of necrosis. You should never see necrosis in high-grade pen. Once you see necrosis, it just becomes intraductal carcinoma. And in addition to that, you want to confirm that it is indeed intraductal, because then in that case it would be grade pattern 5 carcinoma, right, because of the commutal necrosis. So you definitely would need IHCs to confirm that it is indeed intraductal.
You just mentioned something about the pathology after ADT or radiation therapy.
Sure. Right. So anti-androgen deprivation therapy does have a pretty marked effect. And on the left side, the image is a little bit small, but you can see the glands are, and it also kind of goes with what we're looking on in histology. We can hardly see it. You can hardly see it here. It's very bland, it's very pale, and it blends in almost imperceptibly with the stroma. And that's a very classic feature of ADT effect. The glands become atretic, the nuclei become pycnotic, small and black, or very dark, hyperchromatic, I should say. And the cytoplasm gets this very pale, kind of foamy look to it. And you can no longer grade these because there's become so kind of atrophic looking, distorted. If you tried to grade this, it would be way overgraded. It'd be like 5+4 because the cells tend to be kind of single and small and easily overgraded. So we would say prostatic adenocarcinoma with treatment effect, and the comment, Gleason grading is not reliable. Radiation change is another one that can make grading difficult. And in occasion, we can have a patient who was radiated for, say, a 3+4, and then 10 years later, PSA is rising, they do a biopsy. And now we have very malignant, high-grade prostatic carcinoma that looks very viable, and we'll put that in a report. History of radiation is noted, but the prostate carcinoma here is viable and no radiation change is seen. But the radiation changes that you do see, if you're not seeing this high-grade carcinoma and you do see radiation changes, here's some examples here. The cells tend to be very pleomorphic looking. They can get very prominent nucleoli, and they get an expansion of this kind of granular, eosinophilic or red-like quality of the cytoplasm. In addition to that, it can become very vacuolated, so lots of large vacuoles in the cytoplasm and in the nucleus. So the grading can be quite difficult to do. But essentially, in both of these cases, when you have any kind of therapy effect that causes alterations to a point where you can't grade the tumor, these essentially are rendered inert and probably not going to proliferate.
Of course. So, Anthony, I want to thank you very much for a very, very extensive, wonderful discussion. And just to conclude, adenocarcinoma with some small cell features should be distinguished from neuroendocrine prostate cancer, which has a much worse prognosis. Right. Intraductal carcinoma tends to have worse outcomes, and it's associated with high-grade carcinoma. Treatment should include immediate rebiopsy or definitive therapy. and large cribriform glands is an aggressive pattern 4 feature and should be included in the pathology report. I'd like to thank you all very much for listening, and thank you once again to our speaker, Dr. Sisk, who's done a wonderful job, and you can obtain CME credits for this podcast. Thank you very much.
Thank you.